think the RT's part is very small. They don't
Okay.
take too much time. For me, I may take between 10 and 15 minutes to begin.
Okay.
Then RT side will be like 5 minutes. Let's say 15 plus 5. The rest, I think, should do within 10 minutes each. So 15 plus 30, 45. Then the last will be the emergencies. It will be another 10 more minutes. Emergency, is it?
Yeah, only the fact. They will want it.
So I think the problem will be for emergencies, whether we take off the emergencies, just finish off with the decannulation. That's another option.
The emergencies is it like the multidisciplinary part, or is it the medical part?
It's like how to deal with accidental decannulation, how to deal with block, the bleeding Maybe about 10 slides.
Okay.
Initially when we tried, we ran short of time
Do you think it's possible to instead of 10 slides to cut it short into 5? Like, I think the most important message we want to send across is if there's any trachea emergency, they should know who to call. I mean, like, your ICU team or Code Blue team and what needs to be done. I think that's, yeah. Call for help, call for help in that sense, yeah.
Can cut it short, maybe 5 minutes. I can tailor down a bit.
Maybe we can do it like these are the expected emergencies that can happen, like 1, 2, 3, 4, and if that happens, this is what should be doing, rather than going into each in a detailed version yeah.
Right. Okay.
I'd like to test your share screen functionality and some of that.
Can we just share some slides so that we see?
Yeah, we will share the
Grace is sharing.
Okay.
Yeah, I can see. Into the display mode.
Is there any Q&A or those poll questions kinds?
Yes, we can actually create those. Yes, we can create polls. Are you able to create polls? Because I just want to check, because I'm the host, but for all of you, you're panelists, so it may look a little bit different for you. Under polls and quizzes, or under more, are you able to create a poll?
So that means okay, so which view did you go to? Because I don't see the comments here.
Only you can see from one another. Because you're only sharing one.
I see.
So later after the speaker, then you'll just change seats.
Okay, all right. Yeah.
I think the first one I have to go in like that. Yeah. What about the form thing?
Okay.
And okay.
Because we're in the presenter view, right? We will not be able to see the Q&A from the audience.
I don't know.
So who's managing that?
Is that what they did?
No, I'm just looking at this. There's no way we can see the Q&A, the chat.
Maybe I try asking a question.
Yeah. I'll have to open up the chats at the site.
Can you see at the bottom bar?
One laptop you won't be able to see.
Correct, yeah.
Press chat sometimes.
If you open up chats, then
You
will block off the comments, right?
Can I ask a question?
Yes, I can.
Yeah, not from the presenter view, but then I think the rest we can help.
And then I think
Right.
Kiran will track the questions, right, Kiran?
think we will need to have another laptop or a laptop to kind of look through the questions, like, because sometimes it can be a quite challenging to focus on your presentation when there's lots of questions popping up lah. So what I will try to do is all the questions that will come in,
we'll
I
keep it to
will,
the end lah.
yeah, keep it to the end. Sometimes, okay, so yeah, so I'll try to collate the questions. If the questions are similar, maybe we can just say that answering this question, which covers few more questions that have been asked. Yeah, so at the end we can collate an answer. But I think during the webinar also, right? We can try to answer some questions on the chat as well. Yeah. Rather than taking every question online, we can actually answer them on chat as well. So sometimes that's easier for everyone as well to keep it in the time frames.
So, if there's someone that wants to create polls and so on, I can actually make them the host.
Okay. Anyone wants to create any polls, or anyone has any questions or, poll kind of things that we prepared?
No.
No, is it? Okay.
No. I think it will also take some time lah. We can actually, we have already issue with the timing.
Sure.
We can just, yeah.
Yeah, might be better to just consolidate the Q&A at the end, because I don't think we have any polls, and I
Sure.
think we answer questions in the middle. I don't know whether we'll be able to finish all our information.
You need to unmute, isn't it, Grace?
There was a lot of echoes. Dr.
Okay.
Kiran, can you hear Grace?
The voice was very soft,
Okay.
Oh,
but I could hear she was saying something.
Yes. Get them up.
yeah.
I think it would be better if we just collate the questions towards the end of our presentation so that we don't overrun.
Yeah, can.
Yeah.
Yeah. Okay, Ken. So, no, we don't have any polls, Dominic. We will just go with the presentation. I'll start first. Will there anybody else be starting this, or would you be starting, or do I go first?
No, I think he's asking Dominic.
Yeah.
So I just go first, is it?
Sorry, I will have some administrative slides to share, but it'll probably be like during the 12:55.
Okay, Ken.
And then I'll just pass it over to you.
Sure. Okay. So Dominic passes on to me, then I'll pass on to Dr. Ganesh, then
Please.
there's Aarti Lozel, then there's Sister Goping, then there's speech therapist Grace, and then to physio Shahida, and then I take back, and then we will try to Q&A the questions lah. Yeah.
After Shahida, I mean, I should come for the,
Oh, emergency, is it?
Yes,
Yeah.
Dr.
Okay.
Ganesh is taking track emergencies. Sorry, Dr. Kiran, my name is Shuhada.
Shahada,
Oh,
sorry.
Shuhada, is it? Shuhada.
Shuhada, yes, correct.
Shuhada. Okay. Thank you for correcting.
Yeah, it's on the
Shuhada.
first slide.
Ken. Okay, so I won't be introducing everyone before they speak. When I give the initial brief, right, I'll just say we have a interprofessional multidisciplinary approach.
Yeah.
And then I'll just introduce the names and the hospitals and the departments, and then we just follow the sequence lah. Otherwise, that will also take time if I introduce everyone before the talk.
Yeah, can. There's actually a contents page. I don't know, is this something that you wanna do, or?
I think we can just flash it, but no need to go through all the things.
Can we leave it to you to just let them know that this is what we're going to be going through? Then after that, this is Dr. Ganesh's part. when
Okay,
he-
Ken. So I'll just say that this is going to be a very extensive and comprehensive talk, and this is what we are focusing.
Yeah,
Uh,
yeah, sounds
yeah.
good. Yeah,
okay,
okay.
Ken.
Great.
Do we have any videos?
Yes, oh yes.
Can we check trial run the videos? Because
I
sometimes there's
don't think there's sound, but let me try.
Yeah, Dominic, can I ask you a question? Because I
Yes.
think a lot of people now are rushing for the points to get the license renewed. Yeah,
Yes.
that's why we have this problem, have to change it to webinar. Okay, so is it purely by registration, or is there going to be any QR code they can scan and to certify that they already attended
So there will be Zoom will actually produce an attendance record.
Mm-hmm.
So you can actually see how many minutes
Yeah.
and for how long people have attended. The issue is with the people that go to the overflow room to YouTube to watch, I'll likely need them to fill in like a form or something for me to be able to claim the CPE points for them. So
I
I'll
see.
create a form or something, and then they'll need to submit their details there.
Yeah, I'm just thinking because there might be another scenario like in the ward there's only 1 unit of PC. Yeah. So they actually show it in front of everyone. So a few nurses will be sitting there
I
attending.
see.
Yeah. So for this one, we do we have a venue for them to register there?
We
See,
can continue to register via the link, but they will need to mail me the
I see.
list of names directly for me to
Is it
record.
possible to have a QR code? I think that's easier. I mean, both can be done, to be honest, but if there's a QR, we can flash it at the
Yes.
end.
Okay. Yeah, I can put up the QR code for that. Oh, but the thing is, for them to even come in, they would need to scan the QR code already. I think. Oh, for them to put the names up.
Okay.
Oh, I think an easy way is we're going to put up the form SG link for the
yes.
survey for
Yeah.
them to give feedback. So if they provide feedback, then that's easy for me to claim points for them. We can leverage on that too.
Yeah. We suggest to put a QR. Yeah, maybe the QR code
Yes.
of the form SG at the end of the presentation. So whoever attended, they can just scan at the end. Yeah, then register the attendance. Will that be easier? So we'll be who registered and attended. We already have a list, but whoever haven't registered but attended, you can
Yes.
scan the QR.
So I can share the screen now if you
Yeah, we can add to the end of the slide. We
But
put a QR slide.
the end can be a bit longer than somebody want to go in between. How can they?
But if they need to leave, then that means they didn't attend the full session. Yeah, that's another way. Yeah, but also if we drag too long, they're not fair because they have to go off to attend to patients.
Yeah.
Oh, very tricky.
I mean, usually when I was not people at the start.
Or maybe in the middle.
No, then we have to pause.
Okay.
It can just be in the
Put in
chat
the start
function.
lah. Put in the start.
Yeah, put in the chat function, then they can keep on sending reminders or whoever haven't registered. Yeah.
They put in the chat lah. So that we can start with the session, because the moment we put on the start, we cannot move on from that slide.
Yeah.
So I think.
Yeah.
Let's put just start that. Yeah.
Is that okay, Dominic? We put in the chat function. Either to send the link or QR code so that at the beginning you can already scan.
Yeah. Yes, I'll put in the link, I suppose. Because if we wait till the end, then maybe people already have left.
Yeah.
So
Okay.
I'll just put in the link for them to give feedback anytime, and then I will make sure that I can record their professional registration numbers.
Yeah, question.
I think so. We all meet up at 12:45 or 12:30.
So what time are we meeting up on the 19th? 12:45 or 12:30?
Yeah, I think 12:40. I think 40 lah. Just take 40. Yeah.
12:40.
Okay.
Yeah.
So 12:40, we all will assemble here.
No, the level 8 or level 9 MC
Yeah,
room.
I think we better book level 8 or 9. Yeah.
Oh, we are flashing it in the big screen, is it, Kiran?
A big screen? No. I'm just saying to get a better room with the better audio, because our ICU tutorial room sometimes during meetings also cannot hear properly, you see.
Okay.
Yeah, so I think better to have a proper room for this.
Okay. 12:30, then we start. Okay. Sounds like a
3, 4,
plan.
5. We have 5 people. So anyone have a lazy Susan? I just put the computer on it. When it's your turn to present, I just don't have. I go home and search. Maybe I have. So we don't have to change seat. Yeah. So I just push.
We'll be sitting at one row now.
So the person next to it need to change seat. Seat.
Oh, no. Sister
So-
Goping, the level 9, all are wireless now.
Oh, wireless.
Yeah, so
Okay.
they're hi-fi now.
One device.
Yeah, we only use one device, so it's a video.
Then we change seat now.
Yeah, yeah, no problem.
The day pass and then we see how the sometimes being on correct, so we just start with.
Okay. I think then we will practice ourselves, Kiran and Dominic.
Mm.
Okay, I don't need, it will be boring for you, huh?
Okay, can. Thank you.
Can we use this?
Yeah, yeah.
Yeah,
use
yeah.
the link.
Okay. Okay, thanks, Dominic. Thanks, Kiran.
So you want to use the link to
Yeah,
continue,
let's use the
right?
link so
Yeah.
that we can see how we got.
Okay, so
We can use this one.
Yep.
Huh?
So I will.
so you're presenting.
Let's go with that one.
If that one, then doctor, then later got
Oh, you want to do? Oh, okay, because you shared, right?
Yeah.
You are the presenter
I
view.
use this.
So yeah,
Then we
we'll be side by
we
side.
use this seat.
I think it will be more stable.
And not on the. Let me just try also.
Yeah, that's a main thing.
We can use my own timing.
But I'll just time anyway lah. Because I think someone can change
I just plan to write out all my space.
Inside,
Yeah, so that.
We just need to get used to looking at the presenter view with the comment at the side, so that you know when to scroll and everything.
That's right.
Yeah, so can have a go now. Yeah. I need to go at like,
What time?
What time?
I'm training at 1:30, so.
Should be able to finish.
11:40 now. Okay.
Yeah.
Wait,
Yeah.
because anyway, Ramos is not. So
Sorry?
the RT is not.
yeah.
So
Only get shot by.
maybe, yeah.
Oh, and
So I give Kiran's 2 minutes
Mhm.
and this
it
assume.
should take like 1 minute, but okay, can.
Okay, we can start already.
Yeah.
So let's see that Kiran is finishing here. So when you're starting for me now, is it?
When you start on.
Okay, can I will start. Okay, so thank you, Dr. Kiran, for your nice introduction. In the next 10 minutes, I will go through the indications for tracheostomy and how the tracheostomy is being done. Okay. So in this day and age, tracheostomy has become a common practice. More patients with multiple comorbidities expected. Poor outcomes are being admitted to ICU and placed on ventilation. And tracheostomy is often viewed as a way to facilitate earlier transfer out of ICUs to step-down units. So we need to know more about this tracheostomy. So let's start with the definition. Tracheostomy is an operative procedure that creates a surgical airway in the cervical trachea. And we need to be very clear in the beginning that a tracheostomy and a laryngectomy. A laryngectomy is a trachea directly sutured to the neck, but tracheostomy is a hole created in the trachea. So it makes a huge difference when you're managing emergencies, because those who have laryngectomy, they cannot have breathing through the upper airway. They rely on the trachea. A bit of anatomy and physiology. Tracheostomy, trachea is a D-shaped membrane structure, and it extends from cervical C6 vertebra to T4, T5. It's 11 centimeter in length with an idea of 18 to 25 millimeters internal diameter. In terms of physiology, when we do tracheostomy, we should be aware that we are bypassing the upper airway. So the natural warming, humidification, and filtering of the air is lost. The ability to swallow may be altered, and the ability to vocalize is altered as well. In terms of indications, the predominant cause, the indication is the anticipation of prolonged mechanical ventilation. The next is the bypassing upper airway obstruction, like a trauma or cancer in the upper airway. The next comes the airway protection. Those are the neurological patients who have a neuromuscular disease or a stroke with bulbar palsy. And it also helps with facilitation of thermal targeting. And the last is the anticipated need for a repeated airway access like severe OSA. These are the proposed benefits of tracheostomy, like a mortality benefit, improved comfort, easy to ventilate, and faster weaning, increase patient safety, and also it reduces ventilator-associated pneumonia. But evidence is not great out there. To begin with, whether tracheostomy improves the mortality compared to prolonged intubation. I have shown you two graphs side by side. One is the left side is the French study, which shows no change in mortality compared to intubation. On the right side is the 5-year long study done in Taiwan, which shows there is no change in the mortality compared to prolonged mechanical ventilation. There was another study done in Italy in 2024, which showed those who had tracheostomy had higher mortality in 1 year time, about 55% of them mortality rate. They have also poor quality of life. They have difficulty rehabilitation and risk stratification. And they also noticed in this study those who have a so-called pneumonia on the day of having tracheostomy have a higher mortality rate. In terms of patient comfort, yes, tracheostomy has better patient comfort than prolonged intubation. And in terms of physiology, whether tracheostomy reduces dead space, reduces airway resistance, and the studies show that this is a controversial issue. This study particularly shows that there is no significant change in resistance or dead space volume compared to endotracheal intubation.
5 minutes now.
How much?
5 minutes.
5 minutes. In terms of sedation, it has shown that there is less sedation when you tracheostomize somebody compared to keep them on endotracheal intubation. With regards to length of stay, again, it's there is a mixed evidence in the literature. Some studies say there is no reduction in ICU length of stay in hospital length of stay, like this TrackMan study. But there are some studies which showed there is a difference. In terms of safety, this study in particular showed that patients who are discharged out of ICU with the tracheostomy tube had more mortality than those who had their trachea decannulated in ICU. In terms of pneumonia, there is evidence that early tracheostomy reduces the chance of pneumonia, but this TrackMan study, which is the largest randomized control trial, showed there is no difference in use of antibiotics compared with those who have tracheostomy and those who have an endotracheal tube. So, going back to the pronounced benefits, what ends is only a few of them. So, these are the benefits which still remains. There's improves oral hygiene. There's easier airway care and suctioning. It facilitates communication. There is reduced sedation requirement and improved patient comfort. And also it increases provider comfort with a secure airway. So next comes to my next topic, when to do this tracheostomy. We have a key challenge here. We have to avoid performing the tracheostomy to those who are close to extubation or who are not going to be alive in this period. So, is there any evidence for early and late tracheostomy? And there are, if you mix the tracheostomy indication to subgroups, those who have traumatic brain injury, they are benefit from early tracheostomy, and And those who have spinal cord injury also, even though there is no mortality benefit, early tracheostomy reduce the length of stay and reduce mechanical ventilation. In stroke patients, again, there is mixed evidence out there, but the meta-analysis showed that timing of tracheostomy was not associated with the mortality benefit or neurological outcome in stroke patients. But you leave the undifferentiated in Truckman trial showed that give about 10 to 14 days of before you decide on tracheostomy on an undifferentiated population. So in this Truckman trial, you can see that those who are destined to have a late tracheostomy, only half of them had the tracheostomy tube placed. So So, so what do we have from this? All these evidences is timing matters less than appropriateness. So we should shift our focus from when to track to should we even track this patient. Communication is paramount, especially for patients entering chronic critical illness phase. And we should use some prognostic tools like Cohen score, which helps predict 1-year mortality to guide decisions.
Hello. Sorry, yeah, you're muted. Would you like to unmute? Would you like to unmute? Yeah. You cannot be heard on the webinar right now.
Yeah, I
Okay,
think
I just
was
unmute.
thinking when I was listening
Should be
to
able to hear now.
maybe the early late is a bit cut short.
I mean, maybe you can just share the pros and cons in one slide.
Yeah, I mean, these things I think is a bit too much. I only cut short.
Yeah, maybe I just do one.
Yeah. Mhm.
But we'll leave it there for you to just clean up, because I
Yes.
think there's some.
Yeah, yeah. With the team, we should come to.
Yeah, so shall I start? Oh, no, got a lot of echo. Anyone like you? Testing? No more. Okay, right. Yeah, thank you, Louisa, for the presentation. Now I'm going to share nursing management of patients with tracheostomy tube. Okay, so in today's topic, I'm going to cover 5 areas: adequate humidification, suctioning, inner cannula care, cuff pressure monitoring, and stoma dressing. Okay, for humidification, because as Dr. Ganesh has earlier mentioned, patients with tracheostomy lost a natural warming and humidification that usually occur in upper airway. Many of them are kept nearby mouth, which worsens humidification. Hence, oxygen need to be humidified before applying to tracheostomy patients. So this photo is a typical setup of oxygen therapy for tracheostomy patient in hospital. The requisites are listed in the second picture, including items from A to G. For tracheostomy patient, the oxygen therapy is typically prescribed in percentage, not in liters per minute. So to check the amount of oxygen patient is having, we will need to refer to the percentage indicator on the nebulizer adapter, not reading from the oxygen flow meter. Suctioning is a sterile technique for oxygen-dependent patients. To pre-oxygenate patient, set the suction pressure between 80 to 120 mmHg. Introduce a suction catheter without applying any suction. When felt resistance or patient start to cough, withdraw 1 to 2 cm of the catheter and apply suction. And withdraw the suction catheter till removal. The duration should be between 5 to 10 seconds. A simple way that we can use is to hold our own breath when applying the suction. Observe patient during and after each suction attempt. Allow 2 to 3 minutes between suctions for re-oxygenation. For patients using fenestrated tube, please remember to change to non-fenestrated inner cannula when doing a suction for patients. Inner cannula need to be changed every shift to prevent blockage. During the change, one hand must hold the flange, while the other hand removing the inner cannula. Okay, we may need to twist the inner cannula or pull on the ring tab, depends on the type of the tracheostomy. Remove the inner cannula by sliding it downwards and outwards. Rinse the inner cannula with any sterile water in the hospital. Okay, we use sterile long swab stick to remove the secretions. The brush can be kept to issue to patient upon patient discharge. Washing the inner cannula to be placed in a clean denture cup to dry. Dry the inner cannula before putting it back. Slide the inner cannula into position and lock it. Soaking with sodium bicarbonate sometimes it's necessary to help to remove stubborn phlegm. Cuff pressure monitoring. Checking cuff pressure using a pressure gauge manometer every shift to maintain a 20 to 25 cm water. Overinflation may lead to tracheal damage or esophageal impingement. For patients who are on mechanical ventilator, if air leaking sound is heard when the cuff is inflated, please inform the physician. For non-ventilated patients, they should not be able to talk when the cuff is inflated. Please note, for deflating cuff, to use 10 cc syringe to aspirate all the air from the cuff. Okay. Stoma is to be cleaned with sterile saline at least daily or PRN. Inspect stoma site for bleeding, redness, swelling, discharge. Non-fluid gauze or foam dressing are usually used to place under the tracheal flanges to keep skin dry and provide comfort. The dressing needs to be changed whenever it gets wet or dirty to prevent skin irritation. 11 tracheostomy foam dressing is commonly used We do not recommend to cut gauze as a foam thread may enter the airway. We emphasize to have two persons when changing tracheotomy, one person to hold on to the tracheostomy tube while another performs the tie change. The tracheostomy can be secured using cotton tie and commercially available trachea tape. The commercial trachea tapes are either one piece or two pieces. The tape should be changed whenever dirty or wet to prevent skin irritation. Ensure secure but not tight. Usually we allow 1 finger spacing. Okay, so this will be the guide for changing a cotton trachea tie in SKH. Assessment and monitoring. For respiratory status, we monitor the patient respiratory rate, breathing effort, SpO2 and breath exam. Secretion, we have to reevaluate the character and amount of secretions to detect any signs of infection or other issues. For incision appearance, we look for bleeding, redness, swelling, purulent discharge, or odor among the incision site to identify signs of infection or poor healing. Those are the common tracheostomy complications, depends on the duration of the tracheostomy. Okay, so can I just skip, show them? No need to read out everything, right? Yeah, great. Okay. So for tracheostomy patients, we stand by tracheostomy emergency equipment at the bedside, which include suction apparatus, bed valve mask, oxygen, and tracheostomy emergency kit. The tracheostomy emergency kit consists of all these items. Okay, just to emphasize, for the spare tracheostomy tube, those two tubes need to be cuffed. Okay, so those are the items that you usually see at the bedside. Remember not to discard. Okay, so the first one, red color one, will be obturator, and the inner cannula is one at the bottom. Okay, speech valve usually get discarded when they are changing to a new tracheostomy kit. So remember to keep it. And to remember, we need to perform patient and family education for self-care trainings early. Okay, communication, we have to provide alternative communication tool for the family members, for the patient. Okay. And instruct family members when to seek immediate help. Okay, tracheostomy patients can go for shower. Okay, those are the equipment that we can purchase from ST. Okay, so we also need to teach a patient to point the shower head to lower chest or stand with back facing the water. Use a shower shield. For men, they need to cover tracheostomy tube when shaving. These 4 items are the items we can usually get from speech therapist. Okay, for administration of MDI puffs, we can purchase a spacer, okay, just attached to the tracheostomy tube. Okay, when we puff and when patient exhales, we need to ensure the blue flaps, the membrane is moving. Okay, next I'm going to hand over to Grace, the speech therapist, to share more about tracheostomy care. I'm done, 7 minutes, okay. Okay, so some hiccups here and there, okay. Need to smoothen it out. Good, okay, yeah, but Grace, you are just only going to talk about swallowing, not me.
And both are
Both, okay, because when I look at the slide there,
Huh?
when I look at the slide, I'm going to hand over to Grace to talk about swallowing and speech.
So you can just say swallowing and speech aspects, okay? They won't remember.
Okay,
It's still a while to go.
that's fine, okay.
Yeah.
Oh, is it?
Yes, then I think when we teach the ST for competency also, we would suggest that because I think sometimes 80 is a bit too low. I'm not sure, but in nursing care you guys are not different.
Yeah, because this is from one of the application.
Maybe we put 100, 180.
Oh, I put 80 to 100.
Yeah. So you
150, huh?
Yeah, is the one that we learn in school and papers is 100 to 150.
Thank you, Sister Guo Ping. Now I'll be sharing about the swallowing and speech aspects of our track patients. The left diagram is an example of a normal swallow. It starts in the oral phase where food or fluid is introduced in the mouth to be manipulated and broken down into smaller pieces. A swallow is then initiated at the pharyngeal phase where the bolus gets squeezed past the pharynx into the esophagus. During this phase, the epiglottis closes to protect the airway. At the esophageal phase, the bolus is then transported via a combination of peristalsis and gravity to the stomach, where it is digested. The diagram on the right is an example of a patient with a swallowing difficulty, also known as dysphagia, where the bolus enters the airway, resulting in penetration or aspiration, which might lead to a lung infection. Swallowing in trach patients can be more complex due to changes in airflow, sensation, and secretions handling. As such, there are three key areas we need to monitor closely: breath support, secretions management, and risk of aspiration. For trach patients, we will typically only consider starting diet and fluids when the patient's cuff is deflated. Inflating the cuff can mask signs of aspiration and impede normal swallowing mechanics. Whereas a deflated cuff allows for assessment of laryngeal elevation, cough, and vocal quality, which are important indicators of swallowing safety. The modified Evans blue dye test is often used to assess a trach patient's swallow function. This involves feeding the patients orally oral trials of food and fluids colored blue. After swallowing, the patient is tasked to cough with the inner cannula inspected and will require suctioning to check for traces of blue from the trach. If blue dye is noted from the trach site, the patient is deemed to have failed the test and aspirated on the oral trials given in session. This aspiration may not be captured immediately and will typically require further monitoring by the patient and the staff nurses for the next 24 hours after the session. Because the blue dye carries a significant risk of false negatives, we typically recommend an objective assessment to accurately evaluate aspiration risk and guide safe swallowing management. This is especially for the newly created trach cases. There are two types of objective assessments that can be used to assess what food and fluids patients are safe to take. On the left is a VFSS, also known as a swallowing X-ray. In this assessment, the patient is asked to eat and drink food or fluids mixed with barium so that we can see whether or not the food or fluids are entering the wrong way into the lungs. On the right is a FEES. A small flexible scope is passed through the nose to directly view the vocal folds and surrounding structures. FEES allows us to assess for aspiration and also monitor how well the patient is managing their own secretions. In these two pictures, you can see that there is pooling of saliva in the areas surrounding the vocal folds. We typically manage swallowing issues by recommending food and fluid modifications, teaching patients safe feeding strategies just as eating and drinking slowly, reducing distractions during meal times. We also teach